we will go on to our 3D, 4D live demonstration. Professor Lawrence Platt will be performing ultrasound on, I think, 2 patients. He will be using the newest matrix probe to demonstrate to us how it can improve our diagnosis. I was told, in fact, that our LCD projection actually has a lower resolution than the ultrasound image. So what you see on the screen is actually of poorer quality than what you actually get from the ultrasound. Okay, so in other words, the technologies for our ultrasound has improved beyond the technology of our projection.
Can you hear me there?
Yes.
Okay, we're going to try some of the models that we have whose fetuses are not totally cooperative to us, but we will attempt to do our best to demonstrate some of the advances of the new matrix technology. Obviously, we are looking forward to continued advances in this technology because of, number one, the number of elements in it. There's over 9,000 elements in this transducer that will allow us to do many things. Obviously, we can take a regular 2D image. As you see, we're now examining the fetus, just looking to see carefully fetal position, fetal number, looking at the regular resolution that we can see on the 2D system itself. But very clearly, I'm going to try to manipulate this fetus's heart for us, although we can look at the head, and maybe I'll start with just the head and use the matrix array. We'll go into the X-plane, which will allow us, as you can see, to have 2 simultaneous lines of the sections, as I showed perhaps earlier. When you look at the plane, it's a sort of the X-plane and the elevation model. You can see the line on your left that's going through and getting a perpendicular plane through the fetus. Now, if we had Professor Pilu's case with the cerebellum, we would be able to see the cerebellum nicely here, and then look on the X-plane and look at the posterior fossa. So it's, let me increase the zoom so you can see a little bit better. You can see as I touch the line, we can go in and look at the vermis. We can look at the posterior fossa itself. You can look at the distances there, creating the sagittal view that you want to create to make the different diagnostic examinations for any potential posterior fossa abnormality. In this particular case, certainly looks okay. The size of the posterior fossa looks good. The cerebellum shape looks good. I don't think there's any question that we're dealing with a normal posterior fossa here. So you can see we're just in one image. You can get a parallel plane and you can get a perpendicular image to give you the sagittal and a coronal view of the area of interest that you're looking at. And you can see it here. You can see the little, almost the 4th ventricle there very clearly in two views, both the perpendicular and it's almost like a little keyhole effect that you see there. So using the X-plane technology today, and certainly for the years to come, we're going to have our jobs made a little bit easier by looking at simultaneously without having to create a multi-planar type image just on those screens that we're looking at. If we want to look at the fetal heart, I'm going to try to manipulate it around for me a little bit. As you can see, the fetus is not totally cooperative, although then we got the spine. I might as well start on the spine. It's as if I was looking at the interpediculate processes on the spine on the your left image, and you can see as I go through, or I can reverse it the other way. Maybe that'll be the better way as I run the spine, as you would like to see. If you look on your right, you can see that I can go through and look at my interpediculate processes and notice that on those, as you look at the arrow here, you can see that I can see that the interpedicular processes are very nicely formed. The skin is intact. There's no suggestion of a lesion of the spine, and I think that certainly makes a very nice way to look at the spine on every case that you're going to do by looking what you would standardly be measuring and just examining. And here you have both images all at once simultaneously as you take your line cursor, which your X-plane allows you to go through, which is, I think, an exquisite way to do the examination of the spine. Obviously, we put all that together with the cerebellum when we get the hint that there could be something wrong. But if this were a case where we had an abnormal cerebellar shape, running the spine and knowing where we are becomes a very, very important part of our routine examination to make sure that we're not missing any particular malformations. And again, you can see that very exquisitely just running this line across the spine, going from head to the lumbar region, to the sacral region, to really seeing that this is skin intact all the way through without having to even suggest a problem. So now if I can try to get our little heart in the position. This was the best of the two models in terms of the fetus trying to cooperate, but my next trick would be normally if I were examining this patient in my office, I would have her stand up and jump up and down, and if I don't get it the way we want, we'll try to do that in a minute. But one of the things about X-matrix technology, and again, we're gonna learn more and more as we use it over time. You can begin to see here I'm going through on your left the intraventricular septum. It's starting to accommodate a little bit better. You should probably put it on the cardiac mode here, transducer. It's not. There you go. So we're in fetal echo. Again, we have to set up our images as we want. Let me zoom it a little bit first, and we'll clean up the image a little bit. Here you can see an echogenic intracardiac focus, and trying to come from the side. You know, many times in the U.S., the size of our patients are much bigger than they are here. We would come sort of a lateral decubitus view to see if we can get this, and I'm trying to do that in our patient here as well. One of the things that X-matrix technology will allow us to do as well is in the stick acquisition, you know, one of our frustrating points is trying to acquire a 4D stick. The acquisition of it here is much quicker for us when we try to do a stick acquisition when we have it. But here we'll try to look at, as we can see, coming across the intraventricular septum. You're beginning to see on the right, you can see trying to get the outflow tracts for us in a second. We have to get your baby to move for us. You know, living in Los Angeles, we call that a little fetal earthquake. Okay, let's try to get a stick. You want to get a stick? Yeah, let's get a stick here. Hold on, I'll manipulate a little bit more for us. Come on. Push much harder, I'll get a good bradycardia, won't I? We'll just see if we can get a little stick acquisition here for a second. Update. Okay. That's not going to do it for us. Okay. That's all right. We'll try it. We'll try to get her to move. While we're waiting for that, let's go back to the X-plane and wait, whoa, we almost had it. Come on. Okay, go ahead, all right, I think we can probably get that now. We're still not as clean as I'd like it to be. We'll rotate a little bit. You can begin, let me zoom it a little bit better for us. And you can see that there's how clean it is in the acquisition mode. Once you acquire the image, you have much less movement than you would think if you acquired it with a mechanical transducer for the stick acquisition. We're still not in the most ideal location. Let me see if I put color on and we can get something a little bit different if I can get this baby to do what I want it to do. You know what you're having, baby boy or girl? Yeah, got that right. Okay, let's go there. Let's put color on. Okay, let's clean up that image a little bit, and then we'll go over the X-plane again. Still not getting what we want. Not optimal. Let's try moving it a little bit. Should we try the other baby? Huh? Okay, we're going to try switching patients. Maybe we get the baby more. Okay, want to stand up for 1 second? We'll take a quick switch here. Jump up for 1 second. Stand up. I'm going to have her stand up and jump up and down first before I make the switch. Just stand up. Jump. Okay, now back down. It really works. Let's just see if it does it anyways, okay? Oh, there you go. There you go. See that? She stood up and jumped up and down. Look what we got now. So if you don't be afraid to try that because it certainly works. And we'll get on that matrix a sticker acquisition. Much better for us, huh? So if you learned anything, you learned that having a patient stand up and jump up and down works. But you can see, I think, beautiful illustrations of the X matrix, getting a stick acquisition. If you look at the A plane, B, look how beautiful the acquisition is without any question of motion. It acquires it much faster than a standard mechanical will do. Beautiful outflow tracks here. We can rotate any way we want. And you know, once I have this image, I can store it. And I can look in FOSS. I can look anywhere through the plane. I rotate through here in the A plane. I can change my plane of manipulation if I wish to go either way. And then you can see the outflow tracks beautifully, the right outflow track, the pulmonary artery beautifully, the main pulmonary. You can see the bifurcation very beautifully by this simple acquisition that we did. We'll store that now. We'll be able to play with it any way we want. We'll save this data, and we can always come back. Now let's see if this fetus is still in that same position and get an X-plane. And here we go. We got beautifully. Let's go back to update here. That moved a little bit on us. Let's go back to X-plane itself. Let's go 2D. Then we'll go to X-plane, and I think you can see that the clearer now. All right, and then we put our line through. Okay, there we go, and much clearer than before. And if I zoom it up, we'll get our image back to where we were. And there you can compare that to what we just did with the iStick on this. Beautiful capabilities of and as you learn to develop the skills to live scan with the X matrix, you can see that we can get whatever plane. If we want to look at the outflow tracks, same way we did with the iStick capabilities. So we go back again, beautiful valvular formation. You can see the mitral valve, go back into the tricuspid valve. You can see the beautiful formation. We'll put color on and look at the same way and manipulate with the color itself and be able to see the intraventricular septum beautifully well with the color hugging the intraventricular septum. No flow across the intraventricular septum itself at all, both in the X-plane or the four-chamber view that you see very capably. You can see the crisscrossing again on the outflow tracks with the X-plane on the right of your image. Now, if we go back into the 3D mode and go the iStick with the same color acquisition, we can then acquire rapid update. Okay, and let's go back in the zoom, and we see it very carefully, very beautifully. Let's go back to 2D. We'll see it clearer, I think, that way. I'm going to turn the gain up a little bit because I know that on the screen itself you don't see it as clear as we see it on the monitor here. But again, you can see in the left ventricle, you see the echogenic intracardiac focus. I'll back off a little bit, see if we can see a little cleaner now. Then I, again, do my update to get a quick stick acquisition. And again, you can see so nicely in the outflow tracks. I want to bring this down to where we want to be. And then I can rotate through and see whatever plane we want to get at. And we can adjust the location. Again, zooming it back up. If we want to analyze the intraventricular septum, we certainly can do that with manipulation of any stick, as you would any stick acquisition. Again, all the 9,000 elements are allowing us to do this simultaneously. I'll go back again and see if we can get one more X-plane before we look at the other patient, so you can see the combination of patients. I go back to the screen. You can see the resolution is very, very nice. X-plane back on. I think you can see a little bit better demonstration of that here. And if we turned it a little bit, go back to our 4-chamber view that way, put our X-plane back on, and we'll be, come on, quit moving. Oh, come on, baby. There you go. There you go. Oh, I'll go there. Okay, there you see nice illustration again of the X-plane perpendicular to our views to see the views that you want. You can see the outflow tracks. You can notice there that there's the beautiful bifurcation there nicely. If we put color on, we'd see the same way the bifurcation of the pulmonary vessels. And very clearly with one, there's a 3-vessel view. If we go from the top down, we actually can take from the stomach. If you go back up, we'll go back and see all the views, the 4-chamber view, the outflow tracks with the right and left outflow tracks because of the X-plane, and then the 3-vessel view that you can so beautifully see with the trachea where it belongs with no question of a right-sided aortic arch. It's right where it's supposed to be on all sides with the 2 vessels on the same side as the trachea that you can see here. This is a nice active baby that doesn't make it easier to demonstrate, but you certainly can see the kinds of things that we're trying to demonstrate with the X matrix that will be, I believe, the transducer of the future, but some consider it of the present because you have it right here. You can see how exquisitely the color fills the ventricular chamber without bleeding over into the intraventricular septum. Even with the motion of this baby being very active, you just see how it's going all over the place. But I think it's a very nice demonstration of what the capabilities of it is. Obviously, I could use any transducer to see this, but we're trying to demonstrate the capabilities and depth of a matrix transducer, which I think the advances here of the single transducer to allow you to do everything that you want to do from 2D to 3D to stick analysis to the cardiovascular assessment, I think is clearly, I believe, the way that everyone will be going in the future. Sort of a cost-effective way to start looking at your systems that you'll be acquiring to what you want to be able to do. Let's go back to the head for a second. Maybe I can get another look. Baby's head. We unzoom it. And, oh, that's not. Let me go back 2D. And we'll unzoom it. Need a wider aperture. Okay. We can change the res button too to get us different. As you can see here, as I look at resolution versus speed, you can see that I think it's a little bit more exquisite that way. Again, as I show you the anatomical features that we can do, I could even render this thing and look at the palette if I wanted to do the same way. But again, let's go to the X-plane to see the virtues of the analysis of the central nervous system. Again, as we talked about, versus the cardiovascular system of the fetus itself. And let's go back here to put it on a cardiac. And because it's back in a nice position for me. don't move. And I think you can see a beautiful four-chamber view. We can certainly, without going to the X-plane, see what the matrix capability is as a 2D transducer. I think it's beautiful, just simple rotation to look at the right outflow tracks. I can turn it to a short axis view, and we can get a beautiful short axis view. But I think there's the left outflow, beautiful aortic valve, clearly exquisite images with a matrix transducer. So the advances of the imaging quality now that we're seeing in the matrix has certainly come a long way from where the matrix had first come when they had the smaller matrix. And I think over the course of time, we're going to see continued improvement of the matrix technology for what we're trying to do. Is there something anybody else in the audience would like to see before we move to the oral presentations? Here's another X-plane demonstration. Here you can see a beautiful view right there.
Do you have a question for Larry?
Someone want to repeat the question so I can hear it? But there's a beautiful demonstration again, what the capabilities of the X-plane technology will do.
Larry, there's no burning questions, so probably would be time to wrap this up. So we move to the oral communications.
Okay. Thank you very much.